Khalid? Yeah, please come, sir. We can have you. So, sir is going to speak on updates in myopic maculopathy. I think that's a very important topic. We all suffer, high myopic patients developing detachments, schisis, macular holes. So I think that'll be a great presentation. Come, sir, please.
Okay, thank you a lot. It's my pleasure to be here actually coming from Egypt. We have a lot of high myopes like I think Asia also. Pathologic myopia, PM, unlike other types of myopia, causes a loss of best corrected visual acuity, not only the uncorrected. The definition is weird actually. The refractive error of over -5 or -6 or -8, or axial lens over 26 or 26.5, or a combination of both was used to define PM. A definition based on refractive error or axial lens is considered to show just a high degree of myopia. Recently, PM is defined as a presence of myopic maculopathy equal to or more severe than diffuse chorioretinal atrophy. It's a global challenge. Actually, it affects 2 to 3% of the global population, mainly in East and Southeast Asia. Even in Egypt, actually, we have a center of Egypt with a lot of high myopes. And it's a major cause of irreversible vision loss in working age adults. For surgical conditions, we have multiple surgical conditions for pathologic myopia. First is myopic traction maculopathy, MTM, which includes retroschisis, foveal retinal detachment, lamellar or full thickness macular hole, and or macular detachment. OCT is very important as a tool of diagnosis. MTM, as we all know, you have 4 stages. First, extrafoveal, then foveal, and extrafoveal, then entire macula. For the treatment of MTM, it's partial vitrectomy with epiretinal membrane peeling for visually significant progressive MTM. ILM peeling is controversial actually in these situations. Several studies report full thickness macular hole after vitrectomy with MTM, so foveolar ILM sparing technique to avoid this complication. Myopic holes, actually. How to treat myopic holes? Actually, this is very tricky. We can do macular buckle or epiretinal tissues like internal lymphatic membrane, human amniotic membrane, anterior lens capsule if you are doing phaco-vitrectomy, autologous retinal transplant, autologous platelet-rich fibrin or plasma-rich growth factor, or subretinal like Dr. Rizu's human amniotic membrane. This is some pictures of macular buckle, like endoplomb or AGL macular buckle. We can only do vitrectomy with ILM. Can remove it. Just removal of ILM only to release the traction. The traction is fine, and then you put gas or silicone. Or we can do inverted flap. Actually, in such a situation, I like to do all the vitrectomy, use base vitrectomy, and then do the flap in multi-layer, not only one layer like temporal flap, because this situation is a lot of failure. As you see here, is a tennis scraper. Evacuation from the hole. Another picture with ILM, inverted flap. And here is a pre- and post-operative picture of OCT. Multi-layer flap, and then put C3F8 or 20% SF6. Here is a retinal autograph, actually with Dr. Tamer Mahmoud, and this is actually the video of Tamer Mahmoud harvesting part of the retina and putting inside the macular hole using PFCL as to drag his autograft. This is our work actually in Egypt, which we would put amniotic membrane under air and put it on not inside the hole with a very good success rate like Dr. Rizzo. And we move it under air either with steno scraper or with a silicone tip flute needle closed. Also, now we are using plasma-rich growth factor. Actually, we have a big series of 40 patients using this plasma-rich growth factor, and this is very good. With very good result, actually. It's not working. Doing ILM, it's not working. We remove the ILM totally. And then we put supernatant of the plasma inside the hole for 2 minutes on air and wait. Then aspirate this supernatant, and then we put our plate or the mesh. We open the trocar and introduce our PRGF on the hole, and it's kind of sticky, so it will stick 100%. And we leave the patient on air.
Dr. Khaled,
okay.
1 minute to conclude.
Plasma-rich growth factor is characterized by a moderate concentration of platelet, absence of leukocytes, and the use of calcium chloride for platelet activation. The absence of leukocytes is based on the fact that they sensitize matrix metalloproteinase, free radicals, and pro-inflammatory cytokines, which don't contribute and even impair tissue regeneration. It consists of supernatant and is placed for 2 minutes, then PRGF membrane is placed over the macular hole with forceps, and gas was left as a tamponade. This is some pictures of pre and post. We have, in the first 3 months, 100% success rate. After 3 months, we have 4 failures, which is 10% because of dissolution of this membrane. So we can also augment to put ILM over this membrane, which will be very big result. And this is an invitation for you to come to Egypt next April 24, 26, visit Egypt and see the pyramids. Thank you.
I wanted to know, doctor, your opinion on have you used the plombs, any retinal buckles have you used in some cases with a big staphyloma?
No.
So if there's a big staphyloma, what is your option in these patients?
Actually, amniotic membrane. Use amniotic membrane for this. Or now PRGF is very good. Okay. Yeah, very good.
Great. Thank you.
No, Dr. Khaled, in high myopes with staphyloma, the main pathogenesis is there is a relative non-expansion of the retina, and the staphyloma is there, so it is standing up. How do you address that?
Yeah, of course, the buckle is much better. Actually, it's more logic to push it. Like, yeah, I know. But if you put something inside the hole, it may work.
It may work. Yeah. What is the percentage of success in those cases where you are using amniotic membrane in a staphyloma with macular?
I think it's like over 80%.
So there, if I remember right, from Cairo, there were few presentations made on the suprachoroidal injection of Helon.
Yeah, this is by Haber-Rice, actually, yes.
Yeah.
We don't use it, yes.
It's not being used now?
No. Just Haber-Rice only, I think.
Because the Med1 which they were using, even the Med1 company has stopped manufacturing it.
Mm-hmm.
Thank you.
Yeah, Darius is there. Yeah, come Darius. So Dr. Darius Schroff will be speaking to us on amniotic membranes in macular hole surgery. So I think everybody has their own choice what they put over the macular hole to close it. So Darius likes to put amniotic membranes.
So Darius actually is representing Cyrus. Cyrus was supposed to speak, but Cyrus is not.
He wasn't able to make
emergency, it. And Darius is a prolific vitreoretina surgeon from Delhi. So welcome, Darius.
So I'm sorry to present this before lunch because it's going to make you very hungry, because I'm going to talk about HAM in amniotic which is human amniotic membrane in macular hole surgery. So like Curious George, I was always curious to use HAM in amniotic membrane. Tried a couple of times, failed, and found it very difficult to use. Why? There is challenge in visualization. It's thin and translucent, difficult to see. Sometimes you lose the graft. And high myopes, there's very little contrast. So it's difficult to see the membrane. And when you can't see something, it's difficult to use that particular item. Sizing it, we tried cutting it inside, we tried cutting it vanas, then we tried cutting it inside the eye with our curved scissors. It was arbitrary. I was not happy about it. Placement. It sticks to the forceps because there's a chorion side. It's very sticky. And it's not very elegant to keep on trying to shuffle it inside. And then to put it accurately, and then you're trying to shove it into the hole, you're going to cause damage to the RP. So, our principle is do no harm first, as our Hippocrates oath says. So that's what we try to strive for. So I was really frustrated. I discussed with my friend Dilraj Grewal because he had worked on the neurosensory graft. So we worked a workaround for each of these techniques. It's a fun video. Feel happy to, you're allowed to laugh out loud if you find it funny. So here it goes. It has a voiceover. Can you put on the video, please? Sorry.
Surgical toolkit for ham grafting in VR surgery. Dr. Rizzo's group recently described the brilliant concept of human amniotic membrane or ham grafting for recurrent macular holes. However, there is hesitancy in adopting this technique due to difficulty in visualizing, handling, and placing the graft.
Hi guys, hope you're well. So I am going to hold your hand through preparing, making, and roasting the most amazing Christmas roast ham.
Let us guide you through our recipe for ham in VR surgery. We depict a surgical toolkit using 3 S's: staining, sizing, and sliding. First S, staining. It is true that the amniotic membrane is indeed difficult to see. It is white, translucent, and thin. Simply staining it with a few drops of brilliant blue dye solves the problem. Second S, sizing. We need to determine the graft size and then cut it neatly and accurately. We use inexpensive, disposable dermal trephines. We measure the macular hole indices preoperatively on OCT-B scan. After some trial and error, we found that the optimal graft size is roughly the average of the sum of the minimum linear diameter and the base diameter. See how easy it is to get the perfectly sized graft with a dermal trephine. Third is sliding. Accurately and atraumatically placing the ham graft is a major challenge. We use a bimanual sliding technique with a Tano brush and a nitinol flexible loop. Let's see a few cases. The 62-year-old lady presented with failed macular hole surgery done 2 months ago. See how nicely the graft slides in with the bimanual technique using a Tano brush and a finesse loop. Post-operatively, the hole is closed. This RD case came post-operatively with an attached retina but had developed a macular hole and oil emulsification. We did a silicone oil removal and bimanually placed a ham graft into the macular hole. See how beautifully the hole has closed. This was a failed macular hole case who developed a total retinal detachment with vitreous hemorrhage. In such cases, we place the graft under PFO or after fluid air exchange. You can see how we bimanually slide and spread the graft and place it accurately under PFO. Post-operative OCT shows that the retina is attached and the macular hole is closed. This was a very high myope with a posterior pole retinal detachment and a macular hole. In this case, we slip in the ham after fluid air exchange. In such cases, we take the graft size to be twice the MLD. See how scary the pre-op OCT was and how nicely the retina is settled with a ham graft.
Look at this. Luscious. There is no more festive sight than a glazed ham.
With the Triple S technique, we provide you with a toolkit and our recipe for the perfect ham graft in VR surgery.
So that's it. Thank you.
Cyrus, in the first case, you put it below the hole.
Yeah, so
Over the
that's
RB, I thought you should have put it over, no?
no. So there's the two techniques. There's the overlay and there's the underlay technique. And I initially did the overlay, burnt my fingers because when it dislocates, it's really bad for your ego and for the patient. So now I do a very gentle underlay because I think it sticks longer. A second advantage of underlay over overlays, people who are doing overlay, even in the US, some of them are putting PFCL for some time or oil or heavy oil. But with this technique, you can use gas very easily.
And I presume you peel the ILM in all cases prior putting the graft, or you don't peel the ILM?
So initially, I'm basically doing it for refractory cases in which the ILM is already peeled. Like that case with that RD was a young man from Ladakh, and I think Dr. Cyrus is very particular about peeling. So he had peeled arcade to arcade ILM. Then patient came back. There was all this trouble in Kashmir and all. He came back after 2 years, and that time he came with a total RD and vitreous hemorrhage. So we didn't know what went on. Then on the table we saw I said there's no ILM at all to be found because ILM was peeled in the first surgery. So all the cases had already got the ILM peeled.
And what is the vision improvement in these patients, and how many cases you have done with this?
So that's it's a mixed bag. I think the first case I did get something like 6-12 parts vision, but overall, since these are patients which are really, really bad, I don't promise any vision. We just do it to close the hole. And secondly, in high myopes with RD, I think getting an anatomical result is only so difficult. So I think it's mainly, it is a good scaffold. It works as a good kind of bandage, and it kind of lets the retina settle. Vision is not so great in most. So maybe 1/3 or 25% get good vision, maybe about 6-12, but the others maintain vision, or maybe some vision may drop also.
And how many cases have you done? And you on OCT, what we can see in hyper-reflective shadow.
Yeah.
So we know the amniotic membrane do degrade over a period of time. And when did the amniotic membrane degrade over a period of time?
So I think we have about 3-year follow-up, and it still looks white and shiny every time the patient comes. I don't know when it's going to degrade. So I've spoken to some people in the US and all. They also said that they'd see it. I think Dr. Nayak from LVP has a good experience, Dr. Samira. So she also told me at VRSI that it doesn't go away.
So if it doesn't degrade, then how does the vision improve? Because the retina...
The cells migrate over, and in one of them, you see the lines coming above it. Yes, we could.
So I have a question for you. So when do you say after 6 months, 1 year, that now no more vision is going to improve? Do you have a cutoff? Because with the 19 cases which was shown by Dr. Rizzo, who initially did it, they have a certain time frame. If the amniotic membrane stays there for 3 years, you have to have a cutoff point and you tell the patient that now this is what maximum you're going to get.
So I keep that at around 6 months for my cases. Yeah, that's just my practice.
One workaround for this could be, keeping the overlay and then putting some viscose on top as you finish. So that could possibly, because when we do free flaps, the same problem.
So the retina,
like free ILM flaps or neurosensitive grafts, just put a bit of
the neurosensitive grafts don't fly off, but these fly off. I don't know, maybe
just keeping a little bit of visco.
Yeah, visco. Other thing I've started now is autologous blood. We just take the patient's own blood on the table. Anesthetist takes it, we take it out and put a blood drop on.
Actually, I was discussing with a cornea surgeon, and they said if you're going to put in an inlay, you might also put an overlay to help the faster migration. I don't know if anybody has done that, but that's a suggestion.
Maybe. Thanks.
So Vendu has a question if you want to ask.
Mic ache.
Next speaker.
Can the next speaker come up, please?
Parveen, you're ready?
Just we need the
Dr. Parveen said.
So that the luminescence retina overlay the graft will grow and it will be. Like I want to ask you what is the size of the graft you are taking?
So that's what
why I'm telling you that luminescence graft and AMT, I feel it is little bit because the dark sides contract, but they don't contract.
Yes, sir.
It degrades. They become thinner and thinner. They don't contract.
So-
That's my
So Shubhendu, what I think is Dr. Myers has proposed a hydrodissection of the macula. So it's a Myers hydrodissection technique where they go below the macula hole, dissect the macula hole a little bit, and then put in the amniotic membrane graft. And I do not know if you people have done it, but one particular group does it in all their cases for this very reason, that you cannot physically push a graft without creating a space for there.
So size I take is like I showed in the video, the base diameter and MLD, I measure it and I take an average of that because somehow that works. But
I think
that,
we'll stop now
Yeah,
because there are
we'll-
too many questions. Okay.
So, I think we are really doing, Ajay, you're right. I think give a clear space. So, Andre Gomez had discovered technique 41 gauge. And you just lift up the edges, that's one technique. Or, as you said, you use a 41 gauge cannula and subtly inject. So that, and Tamer agrees every time I ask him, is there any problem in tucking? Yes, that's one way of not to dislodge your membrane because you have to tuck whether it's 180 apart or 360 degrees.
Thank you.
Great. So Dr. Parveen Sen is there. She's going to tell us tricks for vitrectomy in diabetic TRD. Over to you.
Mike.
And have Dr. Shubhendu after this.
I'll take you to the vitrectomy for diabetic retinopathy. It is something which is so common that I'm sure each retina surgeon would have done it. So some tips and tricks which I use I can share with you. So TRD is the most common indication of vitrectomy, and I will stick to only that indication. It can be seen in almost 15% of patients with PDR, and with diabetic retinopathy being on increase, we are increasingly seeing it in our clinics. Pre-op assessment is vital, very important. OCT forms a very important part of it, especially if the media is clear. It will give you the extent of the membranes, it will give you the underlying architecture of the retina, how good it is, how much vision can improve, and how much is the urgency. Is it close to the fovea and would you need to intervene very quickly? Second decision, apart from, of course, the systemic problems that the patient is having and you deal with that, second decision is, do you need to give an anti-VEGF pre-surgery to this patient or not? And these are some situations where you would definitely want to give if there is extensive fibrovascular proliferation or if you have a flat fibrovascular proliferation with no posterior vitreous detachment, and if you have, obviously, neovascularization in iris or angle. It helps in reducing the complexity of surgery, the vascularity of new vessel fronts, and intraoperative bleeding is reduced, and somehow I find it makes it easier to separate and find the correct plane. I often give this example to my students I say that wet notes, if you try to separate, they will definitely tear. But anti-VEGF, if you give it, kind of dries up the vitreous layer and the retina, and it is easier to separate without creating breaks. And but it has its own disadvantages. It can have a crunch phenomena where a TRD can extend onto a CRD very quickly, and timing of surgery. It should not be more than a week or 10 days when the crunch phenomena will be at its peak, and usually the ideal time is 3 to 7 days. So with that said, I'll just take you to a few case scenarios, and since the time is less, I will probably not play the whole video. I will just play the important salient features. So you can see here, the principles are that you go in, do a good vitrectomy all around, enter the cone somewhere, and then you make sure that you have cut the peripheral attachments. Once you are into the right plane, you can see that the fibrovascular prolif actually starts rolling into your cutter, and then I am a very ardent fan of the curved scissors, and with that curved scissors I use it as a forceps, as a pick, as everything, and once you keep on lifting it, you identify those pecks and then you cut. So I don't need to use any other instrument. Once in, I finish most of the surgery with the scissors and come out. So this is how you do it, and I feel with the scissors, once you are cutting only the pegs, the amount of bleeding that you get is also much lesser because you are not really cutting through the vessels. So this is how you are proceeding. You can turn the blade of the scissors. You see now I'm using it almost like a forceps or a spatula with my blades closed and nudging it slowly over to show me the. So this is delamination. This is the technique which is taught to you first, and I am still from the old times. This is what I started with, and this is still my go-to technique in most of the cases. So this is in dense vitreous hemorrhage. So dense vitreous hemorrhage with underlying retinal detachment is something which you need to be very careful, because you don't know while you are cutting where the retina is lifted up, and you may end up cutting the retina to begin with. So you layer up the vitreous, and you can see this vitreous hemorrhage is all opaque. So you layer it till you are able to at least know that the underlying retina is attached here. And once you do that, you can see there is how much of TRD is there. If you go in blindly, you would have created a CRD, and cutting and cleaning a CRD is kind of more and more difficult. Again, the same thing, curved scissors to the rescue, and you can see that the retina is thin, and just because of the little drag, that itself can sometimes tear it. So you have to be very gentle. When you use your curved scissors as forceps, the best thing is if you put too much of pull, automatically it will leave, because the scissors is not a forceps. So this is that way adds to your safety. I only cut it when I see the pegs. So this is another way. Then there is another way of dense vitreous hemorrhage that you have. So this is another technique which I use very often, something I call the interface vitrectomy, that once you have dense vitreous hemorrhage, as you go on cutting, there is always a cloud of heme which keeps coming, and it kind of blocks your view. You don't know which way you are going. So temporarily at this point of time, you can see a lot of fresh heme is there. So temporarily at this time, when the smog starts coming, I put the fluid gas exchange on. And you can see once the fluid gas exchange is on, the principle is that the blood will only come into the fluid. It will mix only into the fluid. It will not mix in air. So your view gets better. You are able to pull up and suck all the blood which is there all around, so that this doesn't come and add to the cloud. So once you have done that, carefully picked up all the hemorrhage all around, now at this time, slowly you identify, you see now everything is clear, and now I'm only left with the fibrovascular polyp, and then I go back to my good old scissors, after, of course, putting the fluid back again and removing the air. Now I go back, my view is clearer, my job is more defined, and I'm not bothered by the blood at all. So this makes things easier, simpler, much more in control. So this is one technique. Then this is another case of dense vitreous hemorrhage, which it was so dense that the hemorrhage was stuck on to the posterior capsule and no view. So I have used the chandelier to do the phacoemulsification here. This gives me a retroillumination. So these are some tricks that you use. Once you do a phacoemulsification with your chandelier inside, you are creating an artificial glow, and then you are able to, clear the lens. The lens is not so hard, but the thing is, because the capsule was fully dusted with vitreous hemorrhage, it had to go. You realize it, how dense the vitreous hemorrhage was once you have put the IOL, and then you see that I'm cutting the PC with the cutter. And this, now you realize how much it was blocking the view. So this is another technique, and again, just to quickly wrap up, you may have these kind of TRDs, large fibrovascular polyp from equator to equator. There is nothing but a polyp, and only game is here. You have to find where to enter. That small blob of subhyaloid hemorrhage told me that here there is a separation between the posterior hyaloid and the retina. So I have entered here, I have made an opening with the MVR into that area, and once I enter here, I have got the plane. Now the story is good. You keep on entering slowly into this area. But because it is stuck, so I have to use forceps. I have to use the cutter and the scissors to make these inroads and slowly finish the surgery. So first, Nick, to identify where to enter was the most important thing here. So this is how, again, the whole surgery was finished. This is another one. This is a CRD, combined retinal detachment, where you don't have any posterior scaffold, nothing to hold back. So best is to go with a bimanual surgery to begin with, because the retina is all elevated and jumping. So you hold with the forceps and cut below it. You can see how mobile the retina is, and you have to do a bimanual surgery here. There is no
Parveen,
choice.
if you could wind up.
Yes, this is the last case. No PVD, again, you do a bimanual surgery. In spite of all the care that you take, you may still have intraoperative bleeding, postoperative corneal edema, and so these things have to be taken care of. Most important is the recurrent vitreous hemorrhage, which has to be taken care of. And to conclude, with the advanced surgical planning and sophisticated procedures, we are still able to give good results to our patients.
I think exquisite videos with excellent, tips you gave us, all of us, So, we'll just take two questions now, because I think.
So one is I tend to do the same way, do a fluid exchange, but then I tend to use a little bit of PFCL so that I can do a dissection while no more bleeding occurs. I do not know how much of PFCL use, and I use a lot of proportionate reflux so that I can dissect out membranes. So what is your take on that?
You could do that. If you have cleared the posterior pole, then you can use a PFCL. But if you have to, usually for diabetic patients, we go from anterior to posterior. So actually speaking, your large polyp will still be posterior. In trauma, I use PFCL more often because you can use it to stabilize your posterior pole by injecting. But usually that area will be clear of fibrovascular polyp. But here, as you saw in this case, the whole polyp is there posteriorly. So sometimes the PFCL may actually come in your way of dissection.
At that time with the PFCL, you do a bimanual dissection. So
yes,
it
you can do, but I'm usually able to, clear up and identify my pegs and finish. It's what you are more comfortable with, but generally I think PFCL works best when you have to work anteriorly rather than when you work posteriorly.
If you pick up the membrane from the disc and all the membranes are not cleared, and if you get a bleed on the disc, what are the measures?
So vital thing is what you said already. First rest everything else before you pick it up from the disc. Because there will be very little that you will be able to do. You can't cauterize on it. So then you other than increase IOP and reduce blood pressure, you can't do much. So best is, I initially used to, when we started, we were very happy to peel off the whole thing. Now I make sure I clean up everywhere, make sure there's no attachment to the fovea, and then cauterize it on the small, the stem or the peg onto the, cauterize it onto the disc. Try not to peel it off.
In these cases, sometimes when you dissect all the membranes also, there's a little bit of oozing from the disc.
Yes.
So do you prefer to give an anti-VEGF at the end of the
Yes, you can do that. Anti-VEGF at the end of surgery, a lot of us use. It can be done. It's very useful.
Have you tried glue when it's in intractable
I think
bleeding?
Dr. Malika is here. She has described use of glue for these things. Even Dr. Tyagi is using it. So there's other things which can be used, but I have not used glue till now.
Thanks, Parveen. I think it was a very nice talk and good discussion. So we'll call on our friend Dr. Srinivas Joshi, who's always buzzing and always busy, and he's going to talk to us about fast and futuristic hyperwidth cutter technologies with AI inbuilt.
Thank you so much. I would like to thank the AIOS and the Alcon for giving me this talk, and thank the respective panel for accepting my request to little bit push me up in the order is because of the other presentation clashing, and my sincere apologies to the rest of the speakers. So I have no financial disclosures for this presentation. So we all know that with the dual blade technology and the bevel tip, the dual pneumatic design, and Alcon says that it's nearly around 100% of duty cycle which is achieved at 20,000 cuts per minute, while reducing the acceleration of the vitreous contents into the lumen, which provides both efficiency and the safety. So these advanced ultrawide beveled high-speed probes, they provide increased efficiency by improved duty cycle, more flow for faster vitreous removal. So the bevel tip also provides closer proximity to the retina, allowing more access to the tissue planes. Now, if you see this video, the closer proximity to the retina in the hyperwidth designed for improved efficiency and the stability and the less turbulence. So I'll just come back to this videos after this animated videos. Now you can see these particles coming up into the cutter. with less chattering on the left side, with more chattering on the right side. So how does it implicate? Hypervid probes, according to the Steve Charles, published in the Retina in 2022, has said that probes result in 44% greater maximum flow rate, respectively, as compared to the single-cut ultravit, which was the 10,000. And less pulsatile traction has potential less risk for iatrogenic retinal breaks. So I'll be speaking about the sphere of influence. It's about for the enhanced safety with high precision for the vitreous removal, especially when it's the mobile or the detached retina. So now you can see this video, which I showed in one or two meetings. If you can recognize the left and the right. So it's very difficult to recognize which one is with a 10K and which one is with a 20K. You can see almost a similar turbulence on both the sides, right? So now let's see what it was. So left side, if you see, it is a 10K, and the right side, if you see, it's a 20K. In fact, we see a little more. Some people say that turbulence is seen, but it's almost similar on both the sides. So now if we look at this turbulence, yes, definitely we see the right-hand side is more higher as compared to the left-hand side, is because the right hand have used the vacuum as 650 and the left hand have used the vacuum at 450. So which indicates that lesser vacuum is definitely better for initially for the learning curve when we are using the hypervid blades. Now, let us see this in the detached retina. How does it work in the GRTs? So in GRT, you can see my vacuum is around 300 because this was the initial set of cases which I was operating. Definitely, I could see less mobility of the retina as compared to the 10K cutters. And definitely, you can see the sphere of influence, the vitreous coming to the cutters. The other advantage is you can go more closer to the edges of these retina and trim the retina. Of course, everything is on the vacuum. You can even trim the retina without having more iatrogenic retinectomies. So what does this indicate? Potential reduced acceleration of vitreous content into the lumen, and experimental studies have shown that 28% reduction in the peak traction forces of the vitreous in the hypervid probes. So now you can see the closer proximity to the retina. Even I have increased the vacuum a little bit, but definitely there is less fluttering. So now we compared how close can we go to the retina, and then we use the ImageNet software and tried to compare it. So we kept at it, if 0.5 millimeter is the diameter, then it corresponds to 14 pixels. So we analyzed it using the ImageNet software and how close we are going to the retina, and we saw that it 0.21 or even with 0.19, there was as close to retina without having much fluttering of the retina. So now you can see the scale here, it's around 0.21, and then when we again set it clear, because it is a preset, so how much ever we zoom, it doesn't differ, because we have set the scale as 14 pixels for 0.5 millimeter. So again, if you can see here, it is 0.19. So you can go more closer to the retina, and that shows the efficiency of these cutters. So now, some people argued in the last meeting that you are using a PFCL, you are using the indentation, you are using a double effect, then how will the retina move? So I thought, let me see how it works even without PFCL or without indentation. Now you can see here, all I said is about the vacuum. The vacuum I have kept is very low, but you can see the cut rate remains stagnant. And now you can even cut the retina. It was a case of bullous rheumatogenic retinal detachment. You can even cut the periphery of the vitreous. We see very less movement of the retina. Of course, you need to have a good pedal control, good control over the vacuum. So when I said visualizing the sphere of influence, here we tried the chromovitrectomy using a fluorescein and using the digital filter. So we can see how the vitreous comes to the cutter. So just wanted to show it in this video. And now, as Parveen madam beautifully showed how with the cutter, how with the scissor she is able to do it. But now, even with the help of the cutters also, we can do most of these jobs. These cutters are acting like a multifunctional tool.
Last 1 minute, huh?
Yes. Cutters are working like a multifunctional tool where you can see here, cutting most of these membrane, doing a cutter segmentation, cutter delamination. Although I do not say that it's a universal and you have to do with the cutter in all the cases. I am a big fan of bimanual technique as well. But definitely the cutters are doing a more better job nowadays using a good multifunctional tool. So here I'm going more close. And once the dissection is done, fluid air exchange was done, and this is the 1 week post-op image of that. And lastly, just 10 seconds, I would like to show, even in the detached retina here, this was the case of combined rhegmatogenous retinal detachment. And you can see, just demonstrating, the fluttering is relatively less as compared to the 10K. You can see the vacuum, again, it remains low. And definitely you can achieve a good vitrectomy without having much iatrogenic breaks, even in the highly mobile or the detached retina. I'd like to acknowledge my colleagues and thank you very much for the patient listening.
Lovely presentation, lovely. Good videos. Questions we'll have later. So we'll go to the next speaker. Dr. Subhendra Boral will be speaking to us on managing suprachoroidal hemorrhage, a nightmare of every surgeon.
Very good afternoon. Yes. Thank you, AIOC, for giving me the opportunity to thank you. Today my topic is suprachoroidal hemorrhage. It is the 1 in 1 lakh situation for every ophthalmologist after doing any kind of intraocular surgery. So suprachoroidal hemorrhage, it is a rare condition defined as a collection of blood into the suprachoroidal space, which is actually virtually a very potential space containing only 0.1, only 10 microliter fluid, and its incidence varies after cochlear surgery 0.04 to 1%. We know all the predisposing factors for development of this kind of suprachoroidal hemorrhage, especially it is arteriosclerosis that happens because the arterial wall becomes stiffer, and when there is any sign of sudden hypotony, intraoperative hypotony, that stretching of the blood vessels can cause a rupture and accumulation of blood into the suprachoroidal space. So this is the factor. So sudden hypotony can result in stretching and there is rupture of vessel wall. So arteriosclerosis is the main predisposing factor. So the signs of expulsive hemorrhage always to be expulsive, before creating any kind of hypotony, or you have to anticipate the situation. So any bulging forwards of the iris diaphragm, vitreous starts prolapsing out, there is iris prolapse and prolapse of vitreous to the wounds, all are the anticipating signs of this expulsive hemorrhage. So primary management, it is obviously the tight closure of the incision. Posterior radial sclerotomy, anterior radial sclerotomy, the people are hardly doing it, but still it is described in the literature. The common indications are extreme pain, a persistent flat anterior chamber, uncontrolled elevated intraocular pressure, retinal detachment, central choroidal apposition, retinal vitreous incarceration, or inability to reposite the intraocular contents. All are the indication for drainage. For secondary management of the expulsive hemorrhage, early referral to the VR colleague for an anterior segment surgeon is essential. Post-operative, anytime you can do it up till 2 weeks. Ideal time for drainage is 7 to 14 days after primary surgery because of adequate clot lysis. So surgical management described earlier, it is a radial sclerotomy. With the help of spatula, you can just remove the blood clots from the suprachoroidal space. Even you can do it as a primary procedure or as a secondary procedure. Dr. Rosie T. et al., they have described an anterior chamber maintenance along with SCH drainage with through the anteriorly placed 23 gauge trocar cannula. So our technique is doing vitrectomy, injecting PFCL. So PFCL push from inside and external passive drainage of blood through the non-valved cannula posteriorly placed. You can place it at a multiple position. So coming to the first case, it is sorry, it's not running. Yes, there is hyphema, ACIUL, and central choroidal apposition you can see. And while just introducing that all the ports, you have to be very sure that all the ports should be inside the vitreous cavity. And after clearing the vitreous cavity, you can see there is huge choroidal on the temporal side. So I have planned to do the choroidal drainage from the expulsive drainage from the choroidal side, from the nasal side here, and just removal of the trocar cannula and injecting the PFCL from inside. So internal passive push and external passive drainage of the blood is possible in a sutureless way. Ultimately, we have removed the PFCL and injected the silicone oil 5000 centistock oil. So postoperatively, you can see there is dramatic improvement in the vision, but still, as the IOP was not maintaining, we have not removed the oil. So this is another case where there was a two-quadrant expulsive hemorrhage in the OCT, in the USG, and the videos are not running here. Yes. So this patient, unfortunately, the video was not running. So this patient, patient ultimately gained 6/9 vision after silicone removal and glued implantation, and you can see there is complete drainage of expulsive was possible. This is another case where there is hemorrhagic kissing choroidals and with total retinal detachment, where I ensured that all the ports are inside the vitreous cavity, cannula tips, and I've done the vitrectomy and just see the two stick-like breaks in the temporal side, supratemporal side, and after doing all the kinds of vitrectomy, I've just cauterized the breaks and then injected PFCL just overlying the disc. Now you can see the disc is here. Now inject the PFCL, and slowly the blood will be drained. The subretinal fluid will be drained from the external from the anteriorly placed breaks, and you can see that I'm just aspirating on the fluid. But you cannot judge the suprachoroidal elevation before doing this step. Otherwise, you can see that could have seen that the elevation of the suprachoroidals were not that much apart from this huge apposition of this retinal detachment. So after that, after the surgery, I have you can see there is absolutely there is no suprachoroidal dissolving too much, and postoperatively you can see the retina is attached nicely, although the vision improvement is not that great. This is another patient where 78 years old lady came with a history of attempted phaco. There was appositional choroid and a lot of residual lens matter, and we have placed the port and started the case. Yes, this is the last video. And but we have started the case with the AC maintainer, and after placing all the ports, I've started doing vitrectomy, and removal of all lens matter was done nicely. Then I place one trocar cannula complex into the suprachoroidal place and remove the trocar blade, and then raise the IOP little bit, like 50 to 60 millimeter mercury for a temporary moment, and then just you can see the dark colored suprachoroidal blood is coming out, and I'm doing gentle massage to the other area so that there is a complete drainage of suprachoroidal blood will be possible, and you can see the multiple trocar cannula guided drainage, posteriorly placed cannula guided drainage was possible in a very sutureless way. You can put the trocar cannula complex at any site depending on the ultrasonography elevation of the suprachoroidal area, and as well as the amount of blood that what you have seen intraoperatively. And finally, after it is not mandatory to remove the blood at a single go during your surgery, and after clearing all the vitreous, the macula is rightly, you can just see macula, and injected the PFCL, so the macula is more visible. And then again, I try to drain the blood a little bit more, and finally most of the macula is visible here, and then I removed, yes. Then I placed that 6 millimeter cannula, and then do fluid exchange, settling the retina, and finally removed the PFCL and injected silicone oil 5000 centistroke. So postoperatively patient gained after 3 weeks 4/60, and after 8 weeks 6/24. So better prognosis cases are always SCH involving 1 or 2 quadrants, and poor prognostic factors are presence of retinal detachment, retinal incarceration, kissing choroidals, all these factors. So these are the good prognosis cases. These are the bad prognosis cases. So sometimes you should not remove the oil. So no need to intervene in case of nasal SCH, localized 1 quadrant SCH. So we have published our case report here. Thank you.
Thank you, doctor. I think it was a very detailed presentation. So I think the take-home message is you got to wait for 15 days for the blood to liquefy.
Like at least 7 to 10 days, at least for the adequate clot lines. That should to be confirmed by doing ultrasound.
I was wondering how many maximum cannulas have you put? Because I saw like a pin cushion effect.
5, 6.
5, 6. But I think don't forget to, you can expose the sclera and do your routine sclerotomy, a large one, cut down also, that can also work. We don't necessarily have to do these multiple.
But you have to suture it. That is
you can do that. And sometimes the blood is liquefied, a single sclerotomy can drain the whole suprachoroidal space also if you make a large enough one. Thanks, doctor. Great presentation.
That you don't have to use a valve cannula into this.
Yeah, that's very important. It should be not unvalved.
I think the drainage is complete if we slit and do it.
So I think next we have Dr. Jayanta Shekhar Gua. He'll be speaking to us on managing recurrence in diabetic vitrectomy. Please.
Thanks, Ajay, and thanks for the kind invitation, the scientific committee. And two great institutions I've been a part of in my city of birth, Kolkata, Don Bosco Park Circus and National Medical College. Having said that, my topic is managing recurrence in diabetic vitrectomy. After the videos that Praveen shows, so elegant videos. So this is a difficult act to follow. We all know the primary goals of vitrectomy are to clear media opacity, stabilize the proliferative process, and to increase the retinal blood flow. Now, apart from the recurrence of diabetic macular edema, which is a different topic altogether, I'll dealing with the other recurrent factors and also elucidating the preventive steps that one takes in the initial surgery to prevent these recurrences. That's the recurrent ERMs, as shown in this picture. Now, risk factors for ERM is active PDR. I won't go into theory much. And the interface between silicon and retina is a very important factor because of the accumulation of growth factors. Now, this is a case where is a case of post-siliconal removal recurrent ERMs. You can see the extent of the ERMs from the posterior pole to the periphery, which I just showed. And the membrane peeling here is a different ballgame altogether than the usual ones with the usual vascular epicenters, because the recurrent ERMs don't follow the same pattern as the initial ERMs. So more than you have to release the forceps, follow the vectors, and then sometimes it becomes a gut feeling. See, it could have gone the other way around and created a tear. So, and that's how you remove, and then we will do ILM peeling in this case also after the ERM. That's it. So preventively, whenever we are doing a TRD repair, I routinely follow ILM peeling because it restores retinal elasticity and aids in resolution of the persistent submacular fluid. So this is the ILM peeling that we usually do in TRD cases or in diabetic macular edema cases to prevent recurrent TRMs. Now, breaks. Breaks iatrogenically can occur during dissection of membranes, frequent during vitrectomy for PRD. Of course, it has the significantly lower incidence in the era of 23 gauge and 25 and 27 gauge vitrectomies. But posterior breaks are have a fearful outcome than the peripheral breaks, and only breaks associated with adjacent traction limit anatomical success. Like these atrophic breaks taken from Ramesh et al.'s publication don't need to be done anything. You just leave them alone. Now, how do you reduce the risk of creating breaks? By removing the anterior vitreous next to the sclerotomies. You must be very careful not to completely detach the proliferation from its base sometimes, because it's better to leave these bases alone so that they don't give rise to sciatic formation and later break formation, and use only sufficient diathermy to minimize break formation. And those with tight adhesions that do not connect to the posterior pole are best left alone. And I'll touch upon two aspects here, tackling attached hyaloid by using outside in and then inside out technique. So these are some innovative steps you will go along. I use a lot of posterior depression to tackle the attached hyaloid, as you will see, and use a lift and shave method so as to, because attached hyaloid are our biggest enemies for reproliferation and of course to prevent bleeding. So you can see that your shaving, and as well as sometimes, and you'll see in the later film how you detach successfully the posterior hyaloid. You'll see. And as Srinivas had shown very successfully, these cutters can go very near. Of course, this is not a mobile retina, attached retina, but even if it's a mobile retina, it's very safe to do surgeries. You can see the hyaloid being lifted here very well. And then you cut across and then you have gone into the right plane. As Hemant would also show, going to the right plane is the surgery half done. Here is the inside-out method as it was being discussed, mini PVD as Sangeet calls it. You begin near the disc, create a PVD, and then you proceed along the planes. And you sometimes you have to create an opening near the hyaloid, as you would see in liter film. So you begin near the disc, inside-out method. So these are very important preventive steps to prevent recurrences. And I'll just fast forward some films. So here we complete the rest of the surgeries. And now we'll deal with recurrent hemorrhages. As in the area of smaller sclerotomies, valve systems, controlled intraocular pressure, we don't have much bleeding, but still it's an important thing that we have to deal with in repeat surgeries. And it has not been significantly less in small gauge as compared to 20 gauge. These are the usual causes of recurrent hemorrhages. And the management of recurrent hemorrhage is the usual. Sometimes it clears spontaneously, but revision surgery is often needed. And we'll go to the this aspect of clotted blood. It sticks on the detached retina situation, and then it becomes a difficult situation which you have to manage bimanually by using a bimanual method, very, very careful. And you usually leave a stalk at the end, as you would see, so as not to recreate. Yeah. So I'll go to my last video then. So Aminda was asking how to control disc bleeding. So you create and bimanually you use a suction and a heme stopper, which I used in this case after cutting the stalk. And I press upon that, and in sometimes 1 minute, 1.5 minutes, the bleeding stops. Then you lower the pressure, examine again, and then conclude. Now, another very important steps I want to show. Give me a few more seconds. That these are red flag signs which we often talk about. That to prevent recurrence hemorrhages, we have to go at the very near the vitreous base and clear the hemorrhages, because these are a very common cause of recurrent hemorrhage. And it's very easy to depress, especially in a pseudophakic situation. And even in a phakic situation, it's not as in this case. You just have to never go across diagonally, just put your depressor and so that the cutter remains on the same side, and you, without touching the lens, you can remove those hemorrhages. The last. Now, periphery has to be lasered right up to the aura to prevent, to ensure adequate anoxia so as not to have recurrent bleeds. And last, I'll deal with recurrent detachments. As Praveen showed elegantly, sometimes you have to use air. It's very, after you have cleared the posterior hyaloid, the peripheral vitreous can be effectively cleared very well, as is shown in this case, under air. And
Doctor, you can conclude, please.
Yeah. So last. So this is a tug-of-war technique that I use to prevent, to tackle the recurrent detachments. Sometimes it becomes a crunch-like syndrome. So use 2 forceps and you pull them apart tangentially to tackle these membranes. Thank you so much.
Thank you, doctor. Thank you. So you showed all the medley cases which we can come across in diabetic retinopathy. Thank you so much, doctor. Thank you. So the next speaker we are going to call Dr. Rupak Kanti Bishwas. He'll be speaking to us on his favorite topic, that is retinal autograft in macular hole. He has devised a lot of various techniques for that.
Yeah. I would like to thank AIOS for the opportunity. But see, actually, the initial discussion was there that whatever you can put into the macular hole, it closes. But believe me, this is not a dustbin or this is not a garbage bin that you can put anything and then you can come out of that. Yes, you can close it, but yes, you need to, if you throw something dirty into it, it will smell. So let's see what is happening if you put the right thing at the right place. So I'll just show you a video. You all have seen this is it is a failed macular hole. So where you can just plug in with the residual ILM and free flap and just put it there. So and we'll show you. There are multiple publications are there that the internal ILM plug and gas tamponade causes a persistent and recurrent macular hole closure. Yes, it does. And this is, you can go to the literature, multiple. Treatment of large chronic macular hole with, internal ILM with transposition and tuck technique. Multiple technique has been described. I'll just go through, flip through of modified foveal advancement technique along with, ILM plugging along with or without that. Lens capsular flap also has been put. Manish is here. Manish has done a significant number of cases and published also. Human choriotic membrane, which he has described today morning, Dr. Darius. I'll show you now. Here, if you notice carefully, so all these cases was actually causing a scar here. So if you notice it here. And I'll show one of my ILM plug. Here, this is the case where you can see. Can I get the pointer? So you can see actually it is closed. The macular hole is closed, but everything is totally scarred tissue, which is neural tissue, not matching with the neural tissue. So that's how it is a closure and a successful closure or a functional ability of the tissue. That is the most important what we are looking for the visual improvement. So, and there are another technique has been described for the platelet-rich plasma vis-a-vis inverted ILM peeling for large macular holes. Here also from Arvind, but here also it has been shown that both the technique is equally effective to close the macular hole. But the question comes how the visual functional ability improves or not. So now question comes whether we should put a neural tissue there itself to close the hole and to have the functional ability of that place. So this is a technique which is, I'll just describe you. This is a failed retinal graft where, this is a macular hole surgery has been done, and then this is the recurrent macular hole which has developed RD along with that. So this has been, the nasal retina has been chosen and it has been cauterized, and this flap has been, well taken according to the size of the graft, and it has been put here. Now the question comes, if you have cauterized the margin and you put this retina here, then this margin is actually ineffective margin. This is a dead tissue which is lying there, and it is once the neural tissue which is come in contact with that, one side is have the neural tissue, the other side is having the dead tissue. So yes, it is also functionally, it will have a functional closure, it will have the anatomical closure, but functional ability, again, still we have a doubt. So to avoid this, what I have designed is actually kind of a trephine, which according to the size of the failed hole, and then you increase of 15 to 20% of the size of the hole, and then select that particular trephine. And this was around 450 size of failed hole size, so I have used 550 micron. And then I'll show you, this is a vitrectomized eye, so after that you can just safely go inside the eye and do a trephine, or in a particular, this is I have chosen on the superior, supratemporal area just beyond the arcade area. This is trephination done under saline, and once you, this is the graft, you can see it very clearly, holding in my left hand, and then I did fluid air exchange, and when I'm placing the graft, so that you are holding the graft at one place, and then placing the graft under air, so that there is no change of the position of the upside down or anything. So you just simply place it there, and I'm just tucking it at the margin very gently. You can tuck those margins with the soft tip cannula, and the rest of the fluid you can take out with the flute needle and laser the donor area and come out with the gas. Now I'll show you what I was showing you earlier, that how different it is. Now this is a failed hole which has been closed, and this is the this is the graft area, which is have somehow to some extent similar tissue, which is even we have the better anatomical structure which has been described in the literature as well with this macular hole. And how functionally effective now the question comes. So this is the same case which has been done by multifocal ERG, and it has showing a significant spike at the macular area. So the graft is actually functioning with MFERG proven. And we didn't have the the microperimetry, so we did 10-2, and actually if you see the 10-2, the central area foveal threshold is almost 25 to 29 of decibel, so which is significantly good of those area of that particular graft area. So now the question whether the graft is surviving or not. So the vascularization and the reperfusion of that autologous retinal graft is most important. I'll give you some classic example, which is OCTA has fluorescent angiography, and OCTA has been done, which has shown in a successfully closed macular hole with the retinal graft, and the graft has also taken up quite well. With the central area vascularization is not there, but the marginal vascularization is there. So that's how you have the multiple choices that you need to choose the correct one to prove it.
I think excellent presentation. The trifines go through the 23 gauge, or which gauge, or you have to do a proper sclerotomy?
Yeah, as of now, this has multiple sizes of trifine, which is you have 400 to 1,000 size of micron.
What gauge is it? We require sclerotomy?
No, you need to enlarge one sclerotomy, and as per the size, it will go there. So it is not. It is a fixed size of the tube which goes there, and it has a. So the next question comes whether you are going to injure the choroid or not when you are trifining it. True. I'm sure this is the next question is coming to your mind. No, it does not cause. There is after 350 micron, there is a stop inside that trifine. So the margin, this has a two tube inside. So one is the outer tube which is trifining, and the inner tube which is preventing to go to the choroid. And actually, practically, there is the tissue fill is completely different of a retinal tissue fill and the choroidal fill. So you cannot.
Last question by Dr.
Rupak, when you did the trifine, I noticed you didn't do any diathermy or laser.
No.
You just went directly.
Yes.
So do you, after you remove it, there could be a bleeders. Would you go back and diathermize? We didn't see you do it here.
Yeah, after that you can do the diathermy if there is a significant bleeder. So but most of the time, due to that crush effect, what you are trifining, it's a finer tissue, finer blood vessels. So they get usually closed. Otherwise, I'm doing the laser also surrounding.
Great, doctor. Thanks.
In your series, like all the holes closed, and what is the functional outcome?
Yeah, all the holes means initial 2 cases, which I have not used the larger size of the graft. I used the same size of the graft. That was my failure in first 2 cases, which I have a graft regression and smaller size, and one has the subretinal migration of the graft as well.
Thanks, doctor.
So, Rupak, one question. Would you do an amniotic membrane graft in your cases, or you continue doing your technique?
No, I will, as of now, I will not do, because I have the enough proof that yes, this is a neurotization is occurring, the vascularization is occurring, and this is functionally effective. So I have an option which is, all the purpose of putting the macular hole and closing the macular hole is surviving. So visual improvement, closure of the anatomical closure of the hole, graft bivalve, and neurotization. So all the proof is there. So this is the
So we'll request the next speaker who's there, Dr.
Thank you.
Tarek.
Thanks a lot.
Who will be speaking to us on management of advanced diabetic eye disease, a hope for the desperate. Doctor, please.
Good afternoon, everybody. It's a great honor to present my work here in the All India Ophthalmological Society, and I thank the organizing committee for inviting me. These are the cases I'm talking about, usually single-eyed patients with old-standing diabetes, multiple layers of the epiretinal membranes. You can't even distinguish the macula and the disc. There are so many pathologies here. You can atrophic, very friable retina that is easily torn, contracted, very thick membranes that are much thicker and tougher than the retina itself, multiple epicenters that you have to cut each of these epicenters. All forms of vitreous hemorrhage are there, subretinal hemorrhages, and combined rhegmatogenous and tractional retinal detachment, and plus other pathologies like cataract, glaucoma, rubiosis, iridis. These are the eyes that we are dealing with, and you cannot see these eyes except in two countries, India and Egypt. We are famous of these neglected cases. You also can find the tabletop traction, which is very difficult to separate from the retinal surface, macular hole, very thin atrophic retina, blood vessels obliterated, every pathology. And these are single-eyed patients that you have to do something in order to give them just ambulatory vision. My preferred technique, step 0, I always do this even if only in few cases I don't inject anti-VEGF a few days before surgery. This makes the membranes crispy and easily removed. During surgery, the first step is to remove the core of the vitreous with all of the blood. Then, this is very important, to separate the central vitreous from the peripheral vitreous. This allows you to work on the central vitreous without causing traction on the periphery or causing iatrogenic breaks. Then, the most important step is to identify the cleavage plane between the membranes and the retina. This is very important, and you have to invest in this membrane. After trimming, you do delamination. Don't make any traction over the epicenters. Any traction will cause a lot of troubles. It can tear the retina very easily. After that, you trim these membranes. Then one of the most important and beneficial techniques is to separate the membranes. The segmentation of the membranes is very, very important. Then trim the membranes. Now it can be removed easily. The only membrane that you can remove by avulsion is the NVDs, because the disc will not be torn with you. After avulsing these membranes, then after finishing with that, I do my kinacort stain or triamcinolone staining. I defer staining to the late because it obscures vision. It does not clear completely. Then remove the real posterior hyaloid, epiretinal membranes, shave the vitreous periphery, do the laser, and fill the eye with the final tamponade. This is an example of one of the cases. This is a very big membrane, very tough membrane covering the macula and the disc. So we segment this membrane. We segment this membrane. Now the macula can be seen. Then we trim. After we segment, we trim again. Then we do the bimanual removal of this membrane by cutting the epicenters. Then we trim again the cut area. Bimanual again, trimming again, trimming and trimming. After we remove the membranes, we remove the real posterior hyaloid. Now the retina is seen to be thin and atrophic. We treat the iatrogenic breaks and do the pan-retinal photocoagulation and fill the eye with the final tamponade later on. This is a similar case with a macular hole. So after removing the vitreous and separating the anterior vitreous from the posterior vitreous, we start the bimanual delamination. After that, after removing the membrane, we are using the useful technique of ILM peeling and stuffing the internal limiting membrane inside the macular hole. So this will close the macular hole, and we will end by 360 vision. This is very good ambulatory vision. This man can read using a magnifying lens, and his most of the life is restored. This case with hemorrhagic retinal detachment and a very thick membrane covering the macula and the disc. We can't see the macula or the disc. Now we found the golden plane between the membrane and the retina, and we are investing this membrane. We are cutting the tens of the epicenters that are attaching this membrane to the macular surface, without causing any traction. Now the membrane can be removed completely. and we make drainage retinotomy, remove the subretinal blood, and doing the laser. And this is the case before surgery, and after surgery, again, the man could regain 360 vision, which is good ambulatory vision. These are some cases of the same technique. I have tens of. Now, what are the results? The preoperative vision was only perception of light to counting fingers, maximally 1 meter. Postoperatively, most of the cases could see 360. Most of the patients could see 360. Some patients could see better, but not that much. And we have met all the complications written in every book. All the complications happened. The intraoperative complications like iatrogenic breaks, and this was a rule. It occurred in 35 eyes out of 41 eyes. Iatrogenic macular holes, avulsion of the arcade also occurred in 2 cases, 2 eyes of 1 patient. Lens injury, the early postoperative, severe reaction, especially in phaco-vitrectomy, secondary glaucoma, hyphema, large hematoma under the silicone. This is devastating, and persistent corneal epithelial defects. Late postoperative complications, including persistent macular hole, persistent subretinal fluid that did not disappear, and it took more than 1 year to disappear. So, seclusi pupilli, high intraocular pressure, rubeosis, all the complications can still happen, and you have to be ready for dealing with these complications. Of course, there is not enough time to speak about these complications, and thank you very much.
Thank you so much, doctor. Very exhaustive presentation. Next, Dr. Prashant Bavankule is our next speaker. He's going to speak on 3D vitrectomy in ROP. And after that, we'll have Dr. Tariq Raza Ali, please. That's it. Sorry.
Shall I?
Please go ahead.
Yeah, thank you. Thank you. I'm really sorry to jump up the ladder, I should say, but I had to. One more commitment in the other hall. So, friends, I would be speaking on my talk on. My talk is on basically 3D vitreous surgery for stage 4 ROP. Well, all of us know what is stage 4 ROP. Once there is a detachment because of the fibrous tissue contraction, if it is involving macula, it is stage 4B, and if it is not involving macula, it is 4A. And it happens typically at a PMA age of 41 weeks. Various options of treatment even in stage 4 is lasers. Lasers, if it is a few clock hours restricted, well, you just do the laser anterior as well as posterior to the ridge, and then you can get away in 1 or 2 clock hours. But in majority of the cases, you have to go inside. Scleral buckling was an option when the fibrous proliferation is predominantly anterior, but only if the traction exists anterior to the equator. But remember, this is an indirect way of relieving the traction which is exerting there. And that's the reason why it has only an anatomical success rate of 60 to 75% versus 50% functional success rate. Importantly, there is a myopic shift of -9 diopter, averaging -9 diopter, in spite of buccal removal, which needs a second procedure after about 5 to 6 months. So lens-sparing vitrectomy is the mainstay of the treatment with a success rate which is shown in 4A as to be 75 to 90% and in 4B 66%. Importantly, look at the functional success rate, which is 85 to 90%. And these are the advantages of lens-sparing vitrectomy when we do. Of course, the patient who receive pre-op anti-VEGF, but the pre-op anti-VEGF has to be given at the most 24 hours ahead of the surgery. And any patient who has received pre-op anti-VEGF and lasers tend to behave intraoperatively as well as post-operatively better. So what differently we do was, previously we used to look into the microscope and operate. Well, every one of us have been doing it for years, but now we look at the screen with a Polaroid glasses and operate. Is it only fashionable, or does it offer, even in this complex surgery, some more advantages compared to the microscope? Let us go see through this video presentation. Yes, it offers you a magnification, depth, field of view, illumination, and other advantages, which I would be running you through the thing. So magnification, this system offers is 24 to 40% more than what an analog microscope can offer you. And so look at this magnification at which I am doing an ROP surgery. This is unbelievable. You cannot think. This is a peripheral ridge which I am dissecting with the help of a cutter. Then I might do bimanual surgery. Here I'm pulling the membranes over the ridge, anterior ridge, which is just behind. And remember, let me remind you, this is in an eye which is as small, where 1/3 of the vitreous is already occupied by the lens. So this is a peripheral ridge where I am dissecting, and look at the magnification at which it is. And still, the field of view is as phenomenal, as big as you would love to have. Importantly, the magnification does not compromises on the field of view, but enhances the field of view. Now look at this particular case where you can see that there is a membrane which is attached at one place where I'm picking up, but they have a tentacles attached in the periphery. While I'm pulling this membrane, the counter areas wherever the membranes are existing can be visualized simultaneously, and that is the beauty of having a larger field of view. Now look at the depth of the field, which is 11 to 42% better than an analog microscope, and this is important, and you will see through this video. Here there is a ridge. There is a membrane which is going from the ridge to the posterior surface of the lens. There is hardly any separation, but you can visualize how beautifully you can recognize the various planes, the depth, and you can comfortably visualize the depth of it, and you can have a very without creating any iatrogenic complication, you can do the surgery. This is just behind the lens. Look at the depth perception where you are getting. Yeah, you have certain advantages. You also have some disadvantages. In a digitalized image, the red color always gnaws, and therefore you need a filter which makes it more palatable. And all these videos which you will be seeing is at 1/10 of the illumination which you use in an analog microscope. So what are the aims of surgery? You don't have to do a complete vitrectomy. You don't have to induce PVD. You have to relieve these 4 traction points: ridge to ora, ridge to lens, or ridge to ridge, and ridge to disc to ridge. Disc to ridges, these are the only areas which need to be trimmed. So let us see what we do is ridge to ora. This is a connection where we just trim it. This I have already shown you. Ridge to lens I have shown you. Now this is ridge to ridge, which is more of a circumferential type of attraction where you are using a cutter. Look at the phenomenal depth and field which you are, and this is disc to ridge, which has to be relieved. Now let us see through this complete videos. This is few clock hours of traction in a post laser stage 4 ROP. After having done basic core vitrectomy, here I'm cutting off this is now circumferential traction, that is ridge to ridge connection. And just once you relieve these traction points, you have to add some laser to the areas which were skip areas during the primary laser procedure, and then do a fluid air exchange, and that's it. Now this is another video where you can see the fibrovascular proliferation. You have to be really early entering into such eyes. You do not need to wait for the retina to really get more taut and more be pulled up into the vitreous cavity. And if you intervene early, you can have definitely better results. You have to be very careful. This membranes sometimes are difficult to discern from the adjacent immature retina, and it's only a matter of practice that you learn when not to do it. Now this is another case where you have more severe proliferation in the anterior part of the vitreous. I will just run through these last 2 videos. And once you relieve these tractions, you have to take care of the hemostasis with the help of a minimal cautery. Cautery cannot be very aggressive, otherwise it can lead to further breaks. And once a break in a case of a ROP, the case is almost doomed. Rarely do you need to sacrifice lens, and the only indication is when you have a proliferation anterior to the equator, I should say, that you have a very anterior. So this is the lensectomy which is being done, and after lensectomy, look at the magnification. You are seeing the ciliary processes, and I am doing dissection at the ora, almost the ora. And the magnification and the depth which you can pursue this is the advantage of this particular system. Dr. Dogra sir has proposed this nasal sitting for temporal tractions, and here is what I am doing through this video. Okay. So to summarize, minimally invasive surgery, that is lens sparing vitrectomy, is definite way of tackling a stage 4 ROP. Pre-op lasers and anti-VEGFs improve the success rate. Remember, total vitrectomy, neither PVD is the goal of the surgery. Relief of only 4 tractions, that is reach to ridge, ora, and lens to disc is important. And 3D digitally surgery eases this complex procedure by a unique combination where you see in a very magnified view, a big field of view, and allows you a great depth. So thank you, friends. This is just a tribute to all the patients who trusted, small babies who trusted their eyes with us. Thank you once more.
Thanks, doctor, for your excellent presentation. Just one question only I have. Do you suture the sclerotomies in these patients?
Of course.
Great. Thanks. So next I'll be inviting our invited faculty, Dr. Tariq Raza Ali. He'll be again speaking to us on diabetic membrane shaving. Please, doctor.
Yeah, good afternoon and greetings from Dhaka. Really, I'm very much honored to be here, and I thank our organizers for inviting me. It is not very easy to talk in front of my mentor, Dr. Ajit Babu is here. Anyway, he's a great diabetic membrane shaving surgeon, so I'm talking in front of you that diabetic membrane shaving simple and safe. Please start the video. Run. Yeah. As you know that here after the core vitrectomy, so a lot of cases we have already seen this high-speed multi-purpose advanced cutter has made our membrane removal very simpler and safer. You have to do the core vitrectomy, remove the anterior and posterior tractions, and then find the gap between where you can enter and remove all the membranes. This requirement is to create this potential space between the membrane and the retina. It is not always easy, but here in all my cases I didn't use any any forceps or any scissors. I just cut with the cutter, and it acted very nicely. Just only you have to go through the perfect plane, and shaving is done using the low vacuum but high-speed vitrectomy in shaving mode. That is very important, and you can remove all the membranes as you can see. Here, this is separate new case. You see, you can trim and you can cut in between. And in some cases, you need the back cutting. You see, back cutting is at maximum cutting speeds. The probe is faced anteriorly, and you can cut the membrane. You can use your suction only to remove the membrane and cut in all the cases. This back cutting is very important for shaving these membranes. Another thing is if there is no potential space, you have to cut the vitreous in such a way that inside out dissection is done from the vitreous, that is from the optic nerve, and from center to periphery you have to do the fibrovascular tissue cutting. So these are all the techniques you are using, everybody is using in our cases, but very cautiously to find the gap in between the retina and the membrane. This is the most important, and very slowly and very carefully you have to dissect so that there is no iatrogenic break. This inside-out dissection done detaching the fibrovascular tissue from the optic nerve from the center to the periphery. This is important in some cases if there is no potential space. This is another case. You can see that we have used a suction and then cutter and remove the membrane in slowly in separate cases. This is another case, very adhesion, and you can remove the adhesion with a suction and then find the plane and the cut with your cutter. So these are the cases in day-to-day we are facing in our diabetic patients, and here are so many diabetic membrane shaving patients, that is presentations are here. It shows that everybody, we are facing this type of patients, and in our day-to-day practice, so diabetic presentations are much more also. So just remove the membrane. You see, this is one cutter. Before cutting, you have to use the forceps. In this case, I used. Then after the plane, I used the cutter only. sometimes you can find this type of fibrous sheet or over the retina, and with the back cutting procedure, you can remove all the membranes slowly and slowly. This is done. This is a very cicatricial case, and again we have done this way, this back cutting technique to remove the membrane. Every case is different in diabetic patients. Every patient is different, so we should not. We can't follow the same way. You have to follow all the things in a case. With the cutting only, you can remove the membrane. This is another case. This is a bit simpler case where you have to segment it, then remove. So what I wanted to mention that there is no hard and fast rule. A combination of blunt dissection, back cutting, and sequential alternating suction and cutting is used to segment all the fibrovascular tissue. Thank you, ladies and gentlemen, for your patience hearing.
I think excellent presentation, doctor, and you finished before time, so we have 1 minute to discuss. I would like to say this centrifugal disc convert dissection is my favorite way to go, and I was very happy you showed the video where you pinched up from the disc, because that gives you a true PVD dissection plane and you avoid vitreoschisis. So I totally concur with your way of, initiating this dissection of these complex membranes.
Yeah, but in all diabetics, you should be open, whether you are going from periphery to center or center to periphery, depending upon the type of membranes.
True.
And most of the time, you are using the cutter and suction. Certain times, how do you judge? Yes, this is very adherent membrane, and if I am proceeding with that, either you will create a iatrogenic break, or the heme can be much more, hemorrhage can be much more. How do you decide that on the table?
Yeah, if you use before the surgery, if you use the anti-VEGF, that will create some benefit for the surgeon. And if I feel that some bleeding is there, then what I do, I just stop the bleeding with my cutter. I press over the bleeding. That is one technique. And another, sometimes I raise the suction, that is from 30 to 60.
Most of these retinas are very thin, and when you are doing only cutter suction and doing the membrane dissection or lifting it, there is a very chance that the periphery of the traction area, there can be a slit breaks. And that can be a reason for a recurrent retinal detachment post-operatively. How do you judge that? Because a lot of youngsters are there, they should learn from you.
That is how I will decide. That actually, sir, this case is different, and every case is different. And on the table, you have to decide how to bimanual dissection is there. If you can use that in that way, those cases probably I will go for my bimanual case.
Yeah, you should be very observant in these cases, because the traction and the amount of pull should be very, very guarded.
I think
the moment you are to the edge, there is a slit break formation is very high, and you should you should not proceed further. And those cases you can use intravitreal scissors without any hesitation in relieving the traction. Yeah, you want to say something?
I think that, sometimes we pull it with a cutter and create some iatrogenic break. In those cases, I think this proportional reflux and visco dissection is very important to create the plane.
Yeah, alternate techniques should be be used when there is too much adherence. You should not only say that, because you were saying, well, a lot of times I use only cutter. That in diabetic vitrectomy, you should be ready to use any armamenta not to create breaks, as much as hemostasis and a good clinical outcome.
Yes.
Even a traction detachment persists, doesn't matter, it slowly will regress in the postoperative period. Thank you very much. And now we'll move on to Dr. Sunil Ganikal. Is he there? Hemant Murthy, yeah. Dr. Hemant, please.
Waiting since when? Your friend.
You are in the
I need
branch,
your best
very
friend.
much.
So his topic is detecting secondary membranes during diabetic vitrectomies. That's the biggest bugbear we have in vitreous cases.
Yeah, thank you. Thanks to the AIOS for giving me this opportunity. Audio also I need. So, yeah. Right. So in proliferative diabetic retinopathy, one should remember that the neovascularization breaks through the vitreoretinal interface and proliferates on it, using it as a scaffold. But you should remember there is frequently anomalous separation because of the vitreoschissus, and the outer layer is the secondary membrane. So a lot of times when you're dissecting, we don't realize that there is already, it is an incomplete PVD which is existent, so we need to detect this secondary membrane. And what you generally see is the inner layer. So you need to identify, just to show you how it would look. So what you would be seeing clinically or very apparent is the white paper that you see, but behind it there is a thin plastic sheet. So using a method, basically just to tell you how you could use a method to detect this cleavage plane, I'm just using a needle just to show you that when you start approaching it, what is obvious, you never realize that there is a secondary layer that is present. And by dissecting from the secondary layer, you're able to dissect the membrane. So this is just to show you how would be the real situation when you come to a diabetic membrane. So how do you design this pick? This is a hypodermic needle. I think there's voice if you could, which is just pressed against a metal plate. You would get a fine, bend at its tip. This is enough for you to detect the secondary membrane. You have the audio, please. No? Hey? There's an audio, but anyway, so it's okay. So please continue. Continue. I'll give the audio, yaar. Don't worry. Go back. नहीं यार. Play कहाँ क्या हो गया? हाँ. No, leave this. Huh? So this is how you would find that, you start using the cutter, like what everyone starts, you find that the cutter is a very good dissecting tool. But when you start failing to, remove this membrane because it's very adherent, that is the question that Dr. Ajit put up. Best is to now use the pick. You see that there is a membrane which is extending far beyond. This is the true cleavage plane. So you identify this. You can use any of the instruments to help you in your dissection. So this is just to show you that when you reach a stage wherein further dissection is difficult, you just identify this cleavage plane. It comes out much more easier. So one elegant tool to help you in your dissection. And then you can use the cutter to clear that. So this is one easier method for you in your dissection. Now, how do you detect it? I've just shown you some of these. Now, in this situation, when you see everything very adherent, there are secondary membranes. So use the pick. You will find that it starts dissecting much easier. Everything is very gentle. There is not much undue traction on the membrane because this does not allow you to produce so much of traction. So you just need to dissect. This is the actual cleavage plane. So now once you know the actual cleavage plane, surgery is a lot easier. So this is all just to step up to show you what are the initial steps that you could adopt to help you to identify the cleavage plane, because I know everyone keeps talking about it. So this is another tissue. You know that any further dissection is difficult. Actually, I'm just using a spatula in this just to help you understand that you just need to understand this cleavage plane, which is, extends beyond that what is apparent, clinically apparent. And once you do this, this membrane starts coming out very easily. So whenever you have a situation wherein further surgery is not possible, you know that there is a secondary membrane. It's important because the entire surgery becomes a lot easier. See, this is how I first identify it. I know that there is a secondary membrane here. I use a pick, first identify the secondary membrane. It does not injure the retina. It's a very safe tool because it just produces a gentle scratch. It is much finer than the bent MER blade. Actually, it's a 26, I use a 25 gauge system. So this is a 26 1.5 inch needle. So it's very, very fine. Once I've identified, I know that where the secondary membrane is, I continue further. You see that this is a lot easier. I also am a great fan of just blood dissection, and you just have to cut those small points of attachment that is present between the fibrovascular tissue and the retina. Here I'm using the scissors to help in the dissection, but you would see a majority of work is generally with blood dissection. So these are all very easy ways for what you can understand how you could. Example of a large fibrovascular proliferation very close to the macula, causing traction on the macula. And once you've identified the secondary membrane, here the secondary membrane is seen to extend over the disc and beyond. And once we identify that, the membrane dissects a lot easily. This dissection, then you 1 minute. Yeah, I finished. I think there's not much of. No, these are all just to show you the concept. Then you can use the scissors or to cut off the fibrovascular tissue. So mine was just to, because there are so many presentations on diabetic vitrectomy, I think I just wanted to show some small step that you could adopt when you do diabetic vitrectomy. And this is when you complete the surgery. So makes it a lot easier. Thank you. Excellent. You can conclude. No, it'll just take a minute, just to show you how easy it is. This is entirely with the pick. Hemant, time is up. Thank you, sir. You are not able to progress in the membrane dissection any further. Look out for the second. Let the video run. I have one or two questions that these membranes you are seeing now while dissecting, you have a continuous membrane with multiple attachments. There is intervening areas are there, and you are trying to remove the whole membrane toto. Right. Certain times what will happen is you concentrate on one area and the other area it's giving away. Actually you have seen nitrogen break formation. Correct. So these cases, what would you suggest? You should segment and proceed? We segment. I generally do segment. So it's not that it's going to be, see, one need not remove it all in let's say en bloc, as one would say. That is quite gone. We actually divide them. It's a lot more easier. Certain times you should not think about en bloc dissection. Certain times it's better to segment so that iatrogenic breaks should not occur. Thank you very much. And now can I have Dr. Sunil on the other podium? And he will be speaking on fluorescein angiography assisted vitrectomy.
Good afternoon, everyone. Let me share my limited experience with intraoperative fluorescein angiography during vitrectomy and how does it help in the management of the cases. I don't have any financial disclosures. Basically, we need a digitally assisted vitrectomy system. The advantage is capability of processing the images. The second thing is the pass plan of vitrectomy is performed simultaneously on the same screen while implementing the intraoperative 3DFA. Several angiographic findings and the retinal blood flow changes can be successfully displayed on the screen. Vitrectomy can be performed with a contrast imaging for a minimally invasive and reliable surgery. We all know the primary requisites for the digitally assisted vitrectomy system. Certain changes has to be done on the, this is an important table which shows what are the changes one should do on the panel to get while doing a 3D fluorescent angiographic assistomy. One, you should look at the iris slider, which should be 100% open if you're doing a 3D FA. The gain has to be increased. You have to play around with the filters. The red and the blue filter should be switched off, and the saturation should be totally reduced to 0. 3D FA performed after a mid-peripheral vitrectomy for the amplification of fluorescence emitted from the injected contrast stage and settings of the engine unit is adjusted as shown previously. Basically, you need an excitation filter and the barrier filter. The excitation filter can be fitted to the light source as shown here. There will be a tray or a slide in the synergetic light system which can be used as an excitation filter. The interference filter can be fitted into a microscope, but the light pipe brightness should be reduced to about 60%, and you can inject an intravenous fluorescent angiography. Similar to what you see on after fluorescent injection, either you can have an hyperfluorescence or an hyperfluorescence based upon the lesion which you are seeing. 3D FA can confirm the size, location, and the neovascular status. Recent modification is instead of fitting onto the microscope, you can fit the excitation and barrier filters within the vitrectomy system as well as into the laser system so that you can avoid the fitting of the filter into the thing. These are the intraoperative views which clearly shows the CNP areas, capillary non-perfusion areas, and the neovascular areas. Let me show a case of diabetic vitrectomy. It's a case with a pre-retinal hemorrhage with the membranes. Once you've done the membrane dissection and the clearance of the hemorrhage, peel the membranes. Let me go to the angiographic part straight away. Yeah. Once you inject a fluorescent angiography, you can clearly see the filling of the arteries and the veins, and you can identify the areas of capillary non-perfusion, which are the targeted areas which are abnormal areas, any fronts of neovascularization, where exactly do a laser. So in this area, there is a maximum leakage is there, so you can do a targeted laser or a targeted PRP to that area. So it will add a value to the existing visualizing system to how to treat it, and excessive laser and other things can be avoided. This is another case of diabetic vitrectomy with a vitreous hemorrhage. Yeah, you can easily see the membranes or the contrast of the vitreous also very well seen, and even the fibrovascular attachments, you can trim it. Laser marks are very well seen, and you can see the skip areas also. Once you have done that, you can selectively laser the areas which are suspicious or which needs further augmentation of the laser. Okay. Even the studies have shown the percentage of post-operative vitreous hemorrhage tends to be less in a digitally assisted fluorescent angiographic assisted vitrectomy when compared to the conventional vitrectomy, because you tend to treat all the lesions properly. Now let me show a case of a superior temporal BR vivo which has been lasered already. Once you inject the fluorescent angiographic dye, just observe in the superior temporal quadrant, there will be leakage of the fluorescein in the area of the neovascularization. It's an already being lasered eye. See the leakage. Even the vascular filling is very well appreciated, and you can on the contrast. So advantages is provides an angiographic information and perform the surgery in real time. Optimum retinal photocoagulation can be done to the CNP areas. Location of fibrovascular membranes can be clearly identified, and segmentation and delamination can be performed easily. Retinophotosexity is one of the concerns when performing an intraoperative FFA. Phototoxicity overcome by acquiring an angiographic images by adjusting the iris slider and setting up the gain with moderate endoillumination intensity. Thank you. Thank you for patient hearing.
Excellent. I think I liked the video. It was looking, I was operating in black and white, you know. I liked it. Something different. Very nice.
what made you to do the fluorescein angiography on the table? Same information you could have got pre-operative.
So only thing, all these are non-iris cases. So first of all, when you do it, because the angiography itself carries some risk factors associated with that, because you're doing on a supine position, an on-table patient, and an anesthetic backup. The second thing is some additional information. The only thing which would added advantage is already lasered eyes, which are the areas to treat, and look into the specific areas of treatment. That is the only advantage, sir. Apart from that, I won't think. Yeah. But this can be applied to even to the, not only in I showed only the vascular occlusion cases and the diabetic. It can be applied to the breakthrough hemorrhages in AMD patients and all. You can do an intraoperative FA and other things and all. It will add a value to that.
Ingenuity has different color filters.
Filters, yes.
So you interplay with that.
Filters and the gain.
Do you have any added advantage doing on the table FA compared to those filters?
That's the only thing, sir. One is the contrast, what you get for the dissection of the membranes and other things. The other thing is the targeted laser photocoagulation.
Which is this machine you're using?
Ingenuity.
Ingenuity, yes.
Thanks, doctor.
Okay, thank you very much, Sunil. Now I invite Dr. Manoj Aswade. He will be presenting again experience with 3D digital microscope for modern day surgeries.
TiVo 800.
Good afternoon, everyone. I first of all thanks the scientific committee of AIOS for giving me the opportunity to speak in front of you. I will be sharing my experiences in the 3D visualization system for doing the various types of retinal surgeries as well as the other surgeries. This is just an overview of the 3D visualization system. I don't have any financial disclosures. My job has been already done by Dr. Prashant Bhawankule. He has shown excellent pictures and videos of the 3D vitrectomies in ROP. In last 25 years, I am a retina surgeon, and I was always comparing myself as a horse force in the operation theater. There were so many similarities between horses and retina surgeons, and you also believe that the horse forces are there, and retina surgeons keeps on working and working. Prolonged stamina working is only with retina surgeons. But once I got this system, then I realized that the comfort is a little bit different. Now the whole scenario in the operation theater is different. I enjoy every step and everything in the operation theater. So since last 25 years, I was not seeing anything apart from the microscope only, binoculars only. Now I am completely aware what is happening in the operation theater, and I really enjoys the OT completely. Before that, there was lots of adrenaline secretion. Now I enjoy the work. I also do the work, and lots of secretions of this one, what we can call it as a serotonin secretions. There are so many practical things which are having advantages over the binocular microscope or conventional microscope, which already we know that there is a light required is hardly 10 to 15%. Magnification is good. Even with the high magnification, resolution is not disturbed. Third thing is that depth perception is extremely high depth perception, and there is no change in the color. Natural color are seen. We will see that few of the videos which we have recorded. This was a cataract surgery. You must be wondering why cataract surgery. Nowadays, more than 50% cases are combined surgeries. Even in a difficult situations also, because of the depth perception and depth is pursued well, you can bring the nucleus in the AC and emulsify it completely without causing the endothelial damage. That is the beauty of this one, depth perception. This was a PC rent case referred to me, and you will see that excellent red glow as well as the tissue delineations. You can see that how it is possible to visualize in this 3D visualization or digital visualization system. This is the case, and later on you can implant the lens in the sulcus. This red glow, you can see this wonderful red glow is digitally enhanced red glow. Here also you can see the depth from the lens itself up to the disc. In a single view you can visualize, and the natural colors you can see the vitreous is visible without staining it with the Kennicott also, and the membrane peeling without staining it. It is possible, and in a natural color you can see the colors, and its complete dissection is possible and in a very comfortable position. Here, this was the first case which I have done. Initially, I tried to do. There was no much learning curve. It was said that there is a lots of lag and log. Lag was, I found that there is no lag as such. It was a mental block or mental lag. Once I started, then I started doing the surgeries, and since last 15 months, I am doing only with this 3D system only, with the all difficult cases. What Ajit Babu sir was asking about the dissection, here you can see the in the other end of why the breaks occurs, because you in a high magnification under the microscope you are not aware what is happening in the other end. Here you can see up to the aura, the dissection is under your control. So you do the precise dissection and you are aware what is happening and you are creating a new breaks or not. And in a natural, and in one more advantage of this system is that even during the hemorrhages occurs, bleeding occurs also, the images are not disturbed. One more advantage which I have seen that because of the digital visualization, with the small pupil also, you are able to see complete fundus view. Here the IOL was explanted, this was an 84-year-old patient and pupil was not dilating. We lifted the lens, taken it out, iris claw IOL was put, and you will see that with 1.5 to 2 millimeter, again I went back and removed the visco and remaining vitrectomy was done. And one more advantage is that you get the exact axis, 180 degree, and Callisto system is again incorporated into this one. So you get the axis as well as the marking. Here through 2 millimeter pupil, at the end you can see the complete fundus through this 3D visualization system. Then again in opaque media also, this was a post-injection, anti-VEGF injection, end ophthalmitis was there. And I was not able to see why the fundus picture is not good. Then I realized that there is lots of hypopyon and turbidities in the anterior chamber which was cleaned. And again proceeded without disturbing the lens, touching the lens. And you can see that the posterior hypopyon is there. That is subhyaloid abscess or hypopyon. You can see this one. And then completely we did the vitrectomy, done the laser, and gas was put. And patient is doing very well. See the movement of this. And this visualization system is very good. You can compare with any other systems. And your life becomes very easy because of the visibility. Then once in a while you can see the visibility of this microscope.
You need to conclude.
Yes. This 3D system is useful for the anterior as well as posterior segment. That was the purpose of showing this one. The system is useful for doing all types of surgeries. Even squint surgeries can be done, DCR surgeries can be done, oculoplastic surgeries can be done, even orbital surgeries can be done by using this one and in a comfortable sitting position without giving the trouble to your back and neck. And that is very time necessity for all which we are working almost 8 to 10 hours in the theater. This was another case. You can see that just out of fun in a retina practice, you can see some scope where you can get some serotonin. That is how is the purpose of, and this was a case of microfilaria loea. Thank you very much for giving me the opportunity.
It's already third.
All those things are
3D
there, and this 3D system is the future. And PB sir is sitting in front of me, and Dr. MPS sir was there. I always feel when I got this microscope, first impression was that if this microscope would have been there to these people, then the history of the ophthalmology would have been different.
Can you be ready here?
Thank you very much, sir.
Yeah.
Thank you.
Thank you very much. Dr. Sachin Maholi, he will be speaking on nucleus drop and IOL fixation, a combined surgery.
Good afternoon, everyone. At the outset, I would like to thank AIOS and the scientific committee team for giving this opportunity.
Yes, Sachin.
Well, I think these are the most common cases which are referred to us as retina surgeons, apart from diabetic retinopathies and rigmatinous retinal detachments. Nucleus drops and IOL drops are pretty common referrals for a vitreoretinal surgeon to manage. This, as we all know, could be because of PCR most commonly. PCR can occur at any stage of surgery, especially in cases of hydro procedure. You have to identify it very early. Some signs like pupillary snap, or it can happen during nucleus delivery or a phagofragmentation. This is a video wherein of a PPC which you can see after the hydro procedure. Sorry. After the hydro procedure, as we try to use a phaco probe, you can see the drop which happened immediately after introduction of the phaco probe. So these are the cases wherein we need to assess how to go about, whether you can manage these cases by only the anterior segment, or if the drop is completely gone into the vitreous. See, this is a video wherein vitreous did not come. There was a drop, but anterior hilar did not come into the face. So continued a little bit with the phaco, and then since the nucleus was soft, I used a cutter and managed to remove all the nuclear fragments, did an vitrectomy, and then clean up all the cortex. The rim was quite good, so 3-piece IOL was placed in the sulcus. So you can manage without going into the vitreous, but you need to assess the situation very carefully. What should an anterior segment surgeon do? If attempt only the retrieval is possible and it is readily accessible, don't try to fish it out. Perform a good vitrectomy as much as possible. Avoid to insert, if possible, insert the lens based on the capsular support available. This is one more case I would like to show wherein it was a dropped nucleus referred to us, wherein the nucleus was pretty hard. I tried to trim as much as the vitreous, as much as the nucleus possible with the cutter itself, but you can see the nucleus is pretty hard, so I had to bring it out, prolapse it in the anterior chamber, and deliver it to the section by visco delivery. So after doing this, there was enough rim which I could assess, and then I had to place a rigid lens in the sulcus. So most of these cases can be managed very well with if there is a good support, intercapsular support. So fragmentation we can use if the nucleus is very hard in most of the cases, but most of the cases nowadays we are managing it to bring it out in the anterior chamber and deliver it quite easily because of the suction and tools what we have. So IOL options we can choose based on the capsular support. Either you can place a IOL in the bag if possible. You can use Irish claw, sulcus IOLs, or scleral fixated IOLs. These are the few pictures of different types of IOL which we can use. This is a video which I would like to share. A case, this was a case of IOL drop. There was enough bag available. So what I did was, once I completed the vitrectomy, it was a foldable lens, so there was a PC support also possible. The rent was in the center. So I brought the lens in the anterior chamber and tried to manipulate it in the PC support itself. It was a foldable, so I had to place it behind the anterior capsule. So it was possible. The same lens was placed. I had prepared it for scleral fixation. If you can see, the conjunctiva was open. So the support, so you can assess and do these cases quite easily. So this lens was placed in the bag, even though the PC support was. So scleral fixation techniques are different ways. We can do either suture technique, which is gold standard. You can do a glued IOLs, or you can do a sutureless techniques. So this is a case which had a nucleus drop as well as the IOL drop. You can see the nucleus was, fragments were there, and the IOL which they had put was also dropped. So nucleus came out with the cutter easily. I'm sorry, the videos are running. So this IOL had to be explanted, and then we had to do a sutured scleral fixated IOL. This is one more technique which is a Mani technique wherein you don't have to use sutures. You can do transconjunctival most of the cases. This is a case of dropped IOL. Once the IOL was removed, you need to externalize the folded. This is a 3-piece lens. You need to externalize the haptic through a 26 gauge needle transconjunctivally, bring it out. And once you bring it out, you need to, both the sides we need to do this. Once you bring it out, you need to cauterize the tip of this IOL so that it, see, once you externalize it, use a cautery, don't touch the lens. You can make a knob-like things and you can just push it below the conjunctiva. So these are the different techniques which we can use to manage drop nucleus and drop IOLs. Factors influencing the final outcome, of course, are the timing of surgery when you want to intervene, cornea-related problem, glaucoma-related problem, and vitreous-related traction and retinal detachment. Thank you very much. Thank you.
Thank you, Sachin. I have few queries. One is the nucleus drop. You said it was hard, so I will make it an anterior extraction. You could have used fragmentome in that.
Yeah, but then again we have to go through a 20 gauge port. So
one port, hybrid port you can make. Out of the 3, 2 can be still 25 or 23, and one port will be 20 gauge, and you can finish off the nucleus instead of creating an anterior bigger incision.
The anterior tunnel was already there. This was a SICS job. So.
Okay, that was one. The second is the foldable IOL in the bag with a posterior capsular rent, which is a little bit sufficiently for this thing. With time, what happens is capsule shrinks. With that, the foldable IOL gets pushed into the posterior chamber. This happens in the follow-up. I would like to have the follow-up of that patient for a little longer term. The third
captured the optic, you know.
Yeah, optic was captured. Yeah, it was captured. It did not fall. I mean, it's pretty stable, so I left it like that. Otherwise, I had prepared it for an SFIL.
Because it's always a danger. And the third is in MNS technique. If you see the port of the one of the tunnel, this thing, it is very close to your exteriorization of the IOL. Why did you plan that? In MNS technique,
the port is close to the externalization.
Okay. Almost next to each other, which is a little bit awkward while performing the surgery. Thank you very much for your presentation. And now we will go on to the last speaker, Dr. Ritesh Narula. He will be speaking on intraocular foreign body removal.
Good afternoon, and thank you, AIOS, for giving me this opportunity to present my work. I'll be talking about retained intraocular foreign body. Can I have my slides? Thank you. So, retained intraocular foreign bodies carry quite a special consideration in setting of open globe injuries, and about 40% of open globe injuries, it has been said, that contain at least one IOF piece. And majority of these are work-related, happening in younger and productive members of society. These foreign bodies can be of various type. The location of the foreign body, the composition, size, associated anomalies along with foreign bodies such as cataract, end-off, all we have to consider when we are thinking of removal of these foreign bodies. The techniques can be with the help of a magnet, intraocular forceps, or in a very anterior foreign body which can be approached through a scleral cut down. The method that we choose depends on one which is going to cause least amount of surgical trauma to the patient. I'm going to be highlighting a few techniques which I have used here through a video. So this is first case of a metallic intraocular foreign body with endophthalmitis, a 37-year-old male patient who had a penetrating injury with end-off. So a complete vitrectomy is possible, if possible, to an extent possible. PVD induction was done in this case, and the foreign body was identified and freed from all vitreous adhesion. That's an important step where you want your foreign body to be free. Also, if you're going to take it out from the port, you want to make sure that there is no vitreous in that area as you're taking this foreign body out. You don't want the foreign body to get stuck in your port. That's a magnet being used. You pick up the foreign body, align the vertical axis of the foreign body with the axis of the magnet. the incision which you're going to be using to take it out, it has to be large enough to allow us easily for the foreign body to come out. What happens if you don't give a large enough incision, as was in this particular case, wherein I erred on the size of incision, the foreign body was pretty large, then you're going to have the foreign body getting stuck at the port size site, either because the scleral incision may look large enough, sometimes the choroid is not cut enough inside. You enlarge the incision further and then allow for the foreign body. So whatever you are feeling is the size of foreign body, try and be a little large with your incisions if you are going to be using a scleral incision or your port area to get the foreign body out. Alternatively, if you have sacrificed the lens and you are not going to be preserving the lens, in those cases, you can use a corneal incision to get the foreign body out. This is a video wherein I'll be showing a two-hand kind of a technique where you do a vitrectomy, free the foreign body. I'm making a corneal incision. This is the site which I have chosen is going to be the one which is going to be directly opposite to the magnet which I'm going to be using to pick the foreign body up from the surface. I enlarge my port. The port needs to be enlarged about 20 gauge so that I get my magnet to pick up the foreign body, and then using a handshake technique you can get the foreign body out through your corneal incision. This is another interesting case, a rare case of a copper wire foreign body there, causing chalcosis chalcosis features on the fundus with a cataract which was also showing pigmentation. The cataract surgery was done, the nucleus was emulsified, the vitrectomy was completed, and a wire was detected. Again, herein the forceps was used because the foreign body is not a magnetic foreign body. A forceps was used, all the vitreous was freed around it, and this copper wire was then removed again through an handshake technique. This was thin enough, so it was taken out through the port itself, and then a lens was put. You could see the signs of the fundus changes in this particular eye. Post-operatively, this patient did well to 6/12 vision. What to do with non-magnetic foreign body? Another video wherein the cornea was severely damaged because of a blast injury. He had multiple foreign bodies impacted on the cornea. Herein we had to use our help of our cornea surgeon, wherein a temporary keratoprosthesis was placed after removing the corneal button. The temporary keratoprosthesis was sutured. Subsequently, the vitrectomy was completed and the foreign body was removed with the help of. So this is a keratoprosthesis being secured in place. The AC is formed. The vitrectomy is completed. The fundus had multiple stone foreign bodies. And herein a forceps is used to pick up these foreign bodies after completing the vitrectomy. As always, enlarge the port, and a forceps is used to pick up the stone particle, grasped and taken out. Sometimes, and then subsequently the keratoprosthesis were removed and the graft was sutured in place. This is a post-operative picture of the same patient. Sometimes you may encounter real large foreign bodies which are not easy to grasp either with forceps, and if they are non-magnetic, things become even more difficult, as in this particular case. This was a case of a large wooden foreign body. Sorry. I think the video got stopped in between. Can you play the video again? Yeah. Is it possible to drag it to the last video?
last minute of your presentation.
So sometimes the large wooden foreign bodies, it is difficult to take them out with the help of magnet and forceps.
So what did you use? You can tell
So that particular one we used PFCL to kind of stabilize the float, the posterior pole. It was heavy enough to not allow PFCL to float it up. So PFCL was used, then a vectis was put under the foreign body to take out a large wooden foreign body.
Great.
No,
So I think you've shown a myriad of cases, and I think we've learned a lot. And thank you very much for your
Thank you, and I would like to invite you all on 18th and 19th May at LVPI for our POSS 3 meeting. Welcome you all there. Thank you.
Thank you. We have come to the end of the session 3, and we will be going to start session 4. But before asking the next session chairman to come over, I thank Dr. Ajay Dudani, who has contributed a lot, and the rest of the panel for staying for the whole session and a lively discussion, and all the delegates who have actively participated in this session.
Thank you very much.
Thank you very much. Now I invite Dr. Mahesh Shanmugam. He will be the chairing this session, session 4, from 2:30 to 4:30.